Liver disorders 2, so pathophysiology and diagnostic correlation. So when you come in to get some blood work done, they run a series of different types of panels, and panels will just have multiple tests in them to attempt to diagnose a particular state associated with different organs or organ systems in the body. So we have like a lipid panel, and a lipid panel is going to evaluate all the different types of lipids in your blood to see if you're at increased risk for heart attack or some type of cardiovascular incident, and to monitor the development of like atherosclerosis or treatment to any drugs related to lipid or dyslipidemia, lipid imbalance in the body. Then there's also like hormonal tests, which we'll talk about once we get into the endocrine system and all the different hormones that we would evaluate and whether elevated or low levels of those hormones are associated with particular disease. Then we have metabolic panels. So there's a basic metabolic panel that just basically looks at the ions, your anion gap, and carbon dioxide, different types of substances that are going to be related to metabolism. Glucose is in there. And then there's like a comprehensive metabolic panel or a complete metabolic panel. And in that CMP, that comprehensive test, in addition to evaluating your basic cations and anions, glucose, it's going to then look at some of the liver markers. So, and also urinary tests, which we'll talk about once we get to the urinary section. So with the liver tests, there's tests of hepatic function that are listed here. And this is pretty common of what you're going to see on those liver related tests. So you definitely see the total bilirubin, the AST, or also known as SGOT, the ALT, also known as SGPT, the alkaline phosphatase, total protein, albumin, globulin, and A to G ratio. So we're going to be talking about a few of those tests and some additional tests that you wouldn't normally find in a complete metabolic panel, but more so related to a liver panel. So bilirubin is measured to diagnose jaundice, modest correlation with severity. Bilirubin fractionation, the diagnosis of metabolic disorders or jaundice of the newborn. Alkaline phosphatase, the diagnosis of cholestasis, space-occupying lesions. Aspartate aminotransferase, the sensitive test of hepatocellular disease. So this is your AST. Alanine aminotransferase, sensitive, more specific test for hepatocellular disease. So this is your ALT. Albumin, it's an indicator of chronicity or severity. So when we see hepatocellular disease or we see extreme hepatitis, there's inflammation going on in the liver stops or slows down its production of proteins. It's metabolic action of anabolism or building those proteins kind of slows. So you're going to see a decrease in the amount of albumin in the blood. Prothrombin time is an indicator of the severity of cholestasis. So here you can see aspartate aminotransferase is abbreviated AST, alanine aminotransferase is ALT, alkaline phosphatase is ALP, gamma glutamyltransferase is GGT, and lactate dehydrogenase is LDH. So the aminotransferases, so aspartate aminotransferase, AST, also known as SGOT, cytoplasmic isoform, it's released during liver damage, also found in skeletal muscle, kidney, and red blood cells. So a little bit more general, and increases can be seen in different types of disorders that are not related to liver damage. Mitochondrial isoform is shorter half-life, greater heat stability, and it's increased 15% with liver disease. Macro AST is complexed with Ig, usually IgG, so immunoglobulin G, which is a pretty common and abundant antibody type that's floating around in your bloodstream. Alanine aminotransferase, also known as ALT or SGPT, is more specific for liver damage. It's present in the cytosol of hepatocytes, and levels are typically lower than those of AST. It's not present in the heart or skeletal muscle, so if we see elevated levels of ALT, then we know that that's specific to liver damage. Because it's present inside of the hepatocytes, when we start to see hepatocyte destruction, in other words, liver cells are breaking or they're rupturing, then that's going to release the ALT into circulation, and that's where we can detect heightened levels. So we see heightened levels with all types of hepatocellular diseases. The AST and ALT measurement. So both are measured in coupled reactions by monitoring a decrease in NADH at a particular absorbance. So AST coupled to malate dehydrogenase, oxaloacetate converted to malate. ALT is coupled to lactate dehydrogenase reaction through pyruvate. Both require coenzyme pyridoxal 5-phosphate. AST measurement, assessment of liver and biliary function, skeletal muscle damage. It's dramatically increased 100 times with viral hepatitis, liver hypoxia, and necrosis. There's moderate or modest increases, like 10 times, with autoimmune hepatitis, cholestasis, alcoholic liver disease, cirrhosis, liver carcinoma. It's measured in serum or plasma that's free of hemolysis. EDTA, heparin, oxalate, citrate are acceptable anticoagulants. It's stable in frozen or refrigerated samples. Stability can be enhanced by adding P5P to the sample, and it can also be measured in CSF and urine. ALT measurement, the de Ritis ratio, or AST to ALT ratio, AAR. AST to ALT is typically greater than 1. It's increased in cases of severe liver disease with necrosis, alcoholic hepatitis, cirrhosis, hepatocellular carcinoma. Reflection of the release of mitochondrial AST. Less than 1 in inflammatory conditions, infectious hepatitis. Serum is a preferred sample. Heparinized or EDTA plasma is acceptable. Stable 3 days at room temperature, 1 week with refrigeration. So the diagnosis of liver disease can follow this kind of arrow diagram. So ALT versus AST in various disease states. So in skeletal muscle injury, you'll see elevated AST, but ALT will be pretty much normal. In congestive heart failure, both of them are elevated. In hepatitis, they're both extremely elevated. Cirrhosis, they're both moderately elevated. And biliary obstruction, they're both moderately elevated. Alkaline phosphatase. It's a group of phosphohydrolases with alkaline pH optimum, pH 9 to 10.5. It requires zinc and magnesium for activity. Biological substrate is unknown, but it's involved in a number of metabolic processes. Lipid transport in the intestine, osteoblastic activity in the synthesis of bone matrix, highest in those with high absorptive or excretory function. Liver, bone, small intestine, kidney, and placenta. Serum isoforms predominantly derived from liver and bone. The clinical utility, differentiation of bone versus hepatobiliary diseases. So ALP expression is induced by cholestasis. Elevations are more marked with extrahepatic obstruction, greater than 3 times fold by stone or cancer at the head of the pancreas. The degree of elevation is proportional to the extent of the obstruction. It's also elevated with intrahepatic biliary obstruction, 2 to 3 fold, by cancer or certain drugs. Modest increases are observed in liver diseases affecting parenchymal cells. Less than 3-fold may be normal. Infectious hepatitis, and it will be higher if the damage is associated with canaliculi or biliary stasis. The separation of bone and liver ALP, electrophoresis in the presence of wheat germ lectin retards bone ALP more than liver ALP, so that allows it to be separated by electrophoretic mechanisms. There are immunologic techniques, chemical inhibition, so levacimol preferentially inhibits bone and liver and isos enzymes. Neuraminidase treatment removes terminal sialic acid residues. reduces migration of bone fraction more than liver fraction. Also used to confirm the presence of intestinal isoform. Lacks terminal sialic acid residues. Only ALP isoform is resistant to neuraminidase treatment. So here you can see the liver versus the bone and the migration. So when we don't treat, both of them migrate very similarly, but if we do treat them, the bone migrates less than the liver. So we can see more migration with the liver one, and we can separate it out that way. Laboratory analysis of ALP, enzymatic assays with chromogenic substrates. So we treat it, we use enzymes, and then we're going to measure the color change with spectrophotometrically. Specimen requirements: serum or heparinized plasma, avoid gross hemolysis, avoid EDTA, citrate, and oxalate. Freshly drawn samples should be stored at room temperature. Run as soon as possible, within 4 hours. Activity increases upon standing at 25 degrees Celsius or 4 degrees Celsius. Frozen samples should be thawed and kept at room temperature for 18 to 24 hours to achieve full enzymatic reaction. That's kind of an important point that I just want to go back on. When you are working in the clinical lab, it's very good to always go back to your common sense. So if you know that enzymes are most functional at particular temperatures, and you have something that's coming out of a freezer, and you're going to be using an enzymatic reaction in order to analyze that sample, and the activity of the enzymes that are added to that reaction determines the effectivity of the assay, then obviously you got to let it get to room temperature. You got to let it warm up to the temperature that the enzymes that you're adding to it are going to be able to be functional. So thinking through those processes are going to make you an excellent technologist. Gamma-glutamyltransferase, GGT. It's a membrane-localized peptidase. It catalyzes the transfer of a gamma-glutamyl group from peptides or other compounds to an acceptor molecule, to an amino acid or peptide, to another substrate molecule, or to water. The function: it plays a major role in glutathione metabolism, the transport of amino acids and peptides into the cell, reabsorption of amino acids from glomerular filtrate or intestinal lumen. Serum GGT originates from the hepatobiliary system. It's elevated in all forms of liver disease. Highest elevations are seen with intrahepatic or posthepatic biliary obstruction. High levels are also observed with neoplasms and pancreatitis. Moderate elevations are seen with infectious hepatitis, fatty liver disease, or alcohol or drug intoxication. Urine GGT is usually of a kidney source, elevated with acute renal infection and renal tissue destruction, and depressed with chronic renal disease. The laboratory determination of GGT: you are going to add glycylic glycine, and it causes a color change, and that color change can be read at an absorbance level using a spectrophotometer. Serum free from hemolysis, EDTA plasma, is also acceptable. Heparin produces turbidity in the reaction mixture. Citrate oxalate fluoride depresses the activity by 10 to 15%. The presence of lipemia or icterus may depress the results. It's stable for 5 to 7 days at 4 degrees Celsius or 2 to 3 months when frozen. 5' nucleotidases, microsomal and cell membrane localized enzyme. It catalyzes the hydrolysis of nucleoside 5' phosphate esters at a pH of 6.6 to 7.5. It's measured clinically with AMP. Quantitative amounts of phosphorus are released after 30 minutes of the reaction. AMP can also be hydrolyzed by ALP even at pH 7.5. Clinical utility: it's increased in hepatobiliary disease with interference of bile secretion. There's extrahepatic and intrahepatic clinical utility. Moderately increased with parenchymal damage is predominant. Similar expression pattern as ALP, but more specific for liver disease. Not increased with drug-induced liver disease. Specimen requirements: serum should be used. Avoid chelating anticoagulants, such as EDTA. Other liver function tests, prothrombin time. It's used to distinguish cholestasis and severe hepatocellular disease. If PT is long, repeat the measurement after vitamin K injection, 10 mg SC or IM. Repeat measurement 4 hours later. If it is corrected, then the patient has cholestasis. If it remains long, the patient has severe hepatocellular disease. So you're going to measure it. If it's long, then you treat the patient with vitamin K and you measure it again after 4 hours. If it stays long, they have hepatocellular disease. If it goes back to normal, they have cholestasis. Other liver function tests, urea and ammonia, increased ammonia in infants and children, hyperalumination, Ray's syndrome, infrequent due to congenital defects in the urea cycle, or ornithine decarboxylase deficiency. Its increased ammonia in adults is observed in terminal stages of liver cirrhosis, hepatic failure, acute and subacute liver failure. Decreased serum nitrogen in cases of liver disease without renal impairment. Ray's syndrome occurs in children 2 to 13 years of age. It follows chickenpox or influenza-like disease, and it's associated with the ingestion of aspirin. Fatty infiltration with necrosis of the liver with cholestasis and encephalopathy due to the accumulation of ammonia. Laboratory results would indicate increased ammonia, increased AST to ALT and ALP, and prolonged prothrombin time. So following the flowchart of abnormal liver function tests. So if AST is greater than 3 times the upper reference limit, ALP is less than 2 times the upper reference limit, it's likely hepatocellular disease. If albumin is normal versus decreased, that helps to differentiate acute hepatitis from chronic hepatitis. If AST is less than 3 times the upper reference limit and ALP is greater than 2 times the upper reference limit, it's likely due to cholestatic disease. If albumin is normal versus decreased, that can indicate acute cholestasis versus chronic cholestasis. Both require diagnostic imaging. And then you determine whether it's intrahepatic or extrahepatic. So if it's blocked outside of the liver versus inside of the liver. So this is a really good reference table that I like to draw attention to. So acute hepatitis, you can see where the levels are. The more arrows, the more severe. N means normal. Alcoholic or drug hepatitis, you can see the different possibilities here, and going through here you can kind of determine what type of results you would be seeing in a patient with this type of disorder. You should take some time to review this table. I know on the qualifying exam there's some specific questions about, they're going to give you some liver markers or markers for liver disorders, and you're going to have to evaluate what the more likely cause of the patient's symptoms is. Excretory and secretory function, so bile salts are the end products of cholesterol metabolism. The clinical significance, solubilization of cholesterol in the bile for excretion, facilitation of the digestion of dietary triacylglycerides, facilitation of intestinal absorption of fat-soluble vitamins, bile formation in canaliculi. Bile salts contain 5 to 15% total solids. Transport of bile acids into the canaliculi generates osmotic water flow, also affects secretion of other components of bile, bilirubin, cholesterol, phospholipids. And this just shows diagrams of cholesterol, hydroxycholesterol, CoA, and chenodeoxycholine-CoA, and the different functional groups that define them. Once the primary bile acids are conjugated, they're transported to the small intestine and play an active part in cholesterol and fat absorption. The enterohepatic circulation system. So we have the duodenum, And from the duodenum, we have an influx from the gallbladder, and we also have influx from the pancreas, and that's going to put digestive enzymes into that duodenum. That is the location that you're going to have the majority of emulsification and digestion of fats. So as soon as fat gets into the stomach and into the small intestine, we want to stimulate the release of bile from the gallbladder. So the liver makes the bile and the gallbladder stores it. And it's the gallbladder's job to empty into the duodenum as soon as fats are in the duodenum. If there is an obstruction, a blockage, if there's an inability of this bile to get out, then you're going to see an issue with fat absorption. The effects of hepatocellular disease, so hepatitis or cirrhosis. Fasting serum bile acid levels are elevated due to the regurgitation of bile acids from hepatocytes, and portosystematic shunting allows much higher increases in serum bile acids after meals. Defective bile acid synthesis, abnormalities of bile acid delivery to the bowel. There's intrahepatic or cholestasis or extrahepatic bile duct obstruction, biliary atresia, stricture, stone, carcinoma. Also result in bile acid retention, regurgitation from liver to the plasma. Interruption of enterohepatic circulation of bile acids. 95% of bile acids are secreted during a single enterohepatic cycle, are recirculating bile acids. Significant interruption leads to decreased hepatic bile secretion, resection, inflammation, and bypass of the ileum. Clinical symptoms: the amount of bile acid returned to the liver is reduced. Loss of feedback inhibition results in accelerated hepatic synthesis of bile acids. Serum cholesterol is reduced, used for bile acid synthesis. Serum bile acids decrease, and there's a reflection of ileal dysfunction since the bile acids are not reabsorbed. Clinical analysis, analytical methods, gas chromatography or HPLC. There are enzymatic assays and radioimmunoassay or ELISA. Significance: increased bile acids in fasting state typically indicates impaired hepatic uptake or secretion. Measurements may be used as endogenous clearance tests and confirmed by standard liver function tests. So this kind of just goes back to that whole thing of following the flow chart. So if you are presented with a series of patient results, again, you should be able to evaluate those results to see what is most likely going on with the patient. So cholestasis is a decrease in canalicular bile flow resulting in the accumulation of bile in the hepatocytes and canaliculi. Intrahepatic functional or structural disturbances of the biliary tree. Extrahepatic involves secondary to the obstruction of bile ducts. Choledocholithiasis, biliary strictures or tumors. So this is a diagram again of that biliary tree. So you have the gallbladder here. There is the common bile duct that goes into the duodenum, and then you have the main pancreatic duct. Bile is secreted into the canaliculi. Canaliculi drain into bile ducts. Small bile ducts converge to form the common hepatic duct. It carries bile to the gallbladder, enters and leaves through the cystic bile duct. Upon exit, it enters into the common bile duct, with common hepatic duct equals main bile duct. Joins the main pancreatic duct at the main papilla or ampulla of Vater. Enters the duodenum at the sphincter of Oddi. And here is diagnostic imaging of that. Consequences of prolonged cholestasis. It's due to failure of bile to reach the duodenum. Malabsorption of fat, fat-soluble vitamins. Vitamin A can cause night blindness. Vitamin D, calcium malabsorption, secondary osteomalacia with pathologic bone features. Or vitamin K, easy bruising and bleeding. Most of the vitamin K that we need is actually produced by bacteria in our large intestine. Not being able to absorb that from the large intestine is the issue that would lead to decreased vitamin K and easy bruising and bleeding, because vitamin K does play a major role in clot formation. Accumulation or retention of biliary constituents in the liver. Bilirubin, bile acids, cholesterol. Bile acids leads to pruritus, bilirubin, dark tea-colored urine or tan-colored stool, and cholesterol, hypercholesterolemia or xanthomas. Main cholestatic diseases: primary biliary cirrhosis, primary sclerosing cholangitis, post-transplant cholangiopathy, post-bone marrow transplant, post-liver transplant, and AIDS cholangiopathy. Primary biliary cirrhosis is a chronic autoimmune condition that's characterized by slow progression to cirrhosis. Symptomatic patients typically present with pruritus and fatigue. Cholestatic biochemical tests: you'd see an elevated ALP and elevated GGT. Bilirubin is variable. There would be mitochondrial antibodies, and that confirms the diagnosis with 98% sensitivity and 96% specificity. And then you perform a liver biopsy. Primary sclerosing cholangitis, chronic non-bacterial inflammatory disease of the biliary tree, ultimately leads to narrowing of the bile ducts and cirrhosis. There is a male predominance, younger age of onset, so about 30 years, and it's associated with ulcerative colitis. Clinical course is variable. It's slowly progressive. Eventually, you see bile duct stricture, formation of biliary stones, the development of cholangiocarcinoma, accelerate the course. Diagnosis: typically asymptomatic with an increase of ALP on routine screening. Symptomatic patients present with pruritus and fatigue. Most have ulcerative colitis. Diagnostic radiographic appearance: beating, irregular bile ducts, anti-neutrophil cytoplasmic antibody, ANCA, present in 80% of patients. Gallstones: solid concretion in the gallbladder. Symptoms are similar to those of a heart attack: appendicitis, ulcers, irritable bowel syndrome, hiatal hernia, pancreatitis, and hepatitis. There are 3 major types: cholesterol, pigmented, and mixed. Cholesterol predominate with cholesterol. Pigmented are associated with conditions with increased bilirubin. The bilirubin becomes insoluble or deconjugated, and then you see cholestasis or chronic biliary obstruction. And mixed, the bile is supersaturated with cholesterol. Lithogenesis: lithogenic means cholesterol content of the bile increases or bile salts and lecithin decrease. Cholesterol precipitates from solution. Factors predisposing cholesterol hypersecretion: obesity, aging, drugs, nicotine, and hormones. Factors predisposing a decrease in bile acid secretion: terminal ileal disease, cholestatic disease like PBC or PSC, cystic fibrosis. This is a diagram of how serious gallstones can get. So you can see these are from cholesterol, these are pigmented, these are mixed, and these have calcium carbonate in them. Cholecystitis: so acute cholecystitis is usually due to gallstones. Cholecystitis is sudden onset of pain in the gallbladder. So the most common cause of that would be gallstones. Symptoms include right upper quadrant pain, and it is extremely severe pain that usually radiates through to the back. Nausea, vomiting, fever. Attacks are initiated by meals, but usually occur later at night. Dark urine, tan-colored stool, and jaundice may be observed. It's diagnosed by an ultrasound and accompanying laboratory findings: leukocytosis, fluctuating elevations of bilirubin, ALP, AST, ALT are possible. Laboratory diagnosis of obstructive liver disease: so you have an increase in alkaline phosphatase. You confirm with GGT. If it's not increased, it's possible bone disease. If it is increased, it could be obstructive liver disease, so then you would have to do imaging. Alkaline phosphatase elevations are more marked in cases of extrahepatic obstruction, greater than 3-fold by stone or cancer at the head of the pancreas. Gamma-glutamyltransferase, or 5'NT, would be elevated. So now we're going to move on to different types of hepatitis. So hepatitis is inflammation of the liver. It's diseases resulting in hepatocellular damage. So the cells of the liver are damaged, and that causes inflammation. Symptoms include nausea, vomiting, fever, dark or discolored urine, jaundice. Acute hepatitis can be toxic or infectious. Chronic hepatitis is chronic inflammation of the liver that persists for at least 6 months. It's characterized by ongoing inflammation, assault on the hepatocytes. So toxic hepatitis is induced by drugs or toxins. Acetaminophen or Tylenol is the most common cause in North America. Nonsteroidal anti-inflammatory drugs, NSAIDs, can also cause this. So it produces a reactive metabolite, and then there's immune mechanism or a non-immune mechanism, and both of those lead to cell damage. Acetaminophen-induced hepatitis, so Tylenol-induced hepatitis. You can kind of see the flow chart here and how this progresses, eventually leading to cell necrosis. Alcoholic hepatitis, so critical stage in the progression to cirrhosis, characterized by fatty liver, and there is a difference in fatty liver that's non-alcoholic versus alcoholic. So alcoholic fatty liver disease is caused by alcohol consumption. Non-alcoholic fatty liver disease is caused by other outlying factors, which we will get into in a little bit. Hepatomegaly is liver enlargement with inflammation and necrosis. Other symptoms: anorexia, means you don't have an appetite, weight loss, fever, infection, pancreatitis, GI bleeding, ascites or accumulation of fluid in the abdomen, and encephalopathy, that's infection or inflammation of the brain. It's diagnosed histologically. Fibrosis and iron deposits are prominent. Inverse correlation between liver iron staining and the survival of alcoholic hepatitis or cirrhosis. Iron deposits are due to increased iron absorption due to folic acid deficiency. Mallory bodies are present in 76% of patients. Alcoholic hyaline, also observed in Wilson's disease, primary biliary cirrhosis. Irregularly outlined homogeneous meshwork of eosin staining material in the cytoplasm of the liver cells. Serum bilirubin. Prothrombin time is the most reliable prediction of the severity of prognosis. ALP parallels bilirubin, and it's 2 to 4 times normal. Minimal to moderate increases in ALT, AST. AST is greater than ALT. If AST is less than ALT, it's indicative of a chronic condition. It may appear more severe with deficiency in pyridoxal 5-phosphate. Increased GGT correlates with and induced by ethanol ingestion rather than liver damage. Screening test for alcohol consumption. Then we go on to infectious hepatitis. Bacterial hepatitis, like Leptospira icterohemorrhagiae, Weil's disease, transmitted by the urine of infected rodents. Flu-like illness, which may progress to liver involvement, characterized by jaundice, hemorrhage, bruising, nosebleeds, renal impairment, and this is often fatal. Mycoplasma, prokaryotic cells with a single membrane. Rickettsia, small pleomorphic coccobacilli, obligate intracellular organisms, and that's the cause of typhus. Viral hepatitis. So we have our hepatitis A, B, C, D, E, G viruses, and then there's transfusion transmitted virus. Other viruses include cytomegalovirus, Epstein-Barr virus, and herpes simplex virus. So diagnosis of acute viral hepatitis, massive increases in AST and ALT, 4 to 200 times. The de Ritis ratio, AST-ALT is less than 1. The release of cytoplasmic AST and ALT with necrosis. There is little change in ALP or serum albumin. Severe cases are associated with prolonged prothrombin time, decreased serum albumin. Etiological diagnosis is made serologically. So hepatitis A virus. There is a vaccine against hepatitis A virus, and most kids are given this. Hepatitis A is usually a transient infection that causes self-limiting diarrhea. So once you get it, You may see a little bit of swelling in the liver, but typically symptoms subside within a couple days with no major complications. It's a picornavirus, small RNA virus, infectious hepatitis or short incubation hepatitis. It's transmitted via contact with oral secretions or stool. It is the fecal-oral transmission and may be transmitted sexually. It accounts for 47% of clinical hepatitis in the United States. It presents like flu-like illness, incubation period of 15 to 50 days, which means after you're exposed, it takes 15 to 50 days before you actually have those flu-like symptoms. Jaundice may develop. Disease is more prolonged and severe in patients over 50 years of age. No chronic form exists. There's no carrier state, or carrier state is short-lived. For diagnosis, anti-hepatitis A virus IgM appears early and persists for 2 to 6 months. Anti-hepatitis A virus IgG is towards the end of the acute disease. It peaks within 1 to 2 months and persists for several years. It conveys lifelong immunity. Antibody titers may be positive without previously apparent hepatitis A virus infection. And then there is the presence of the virus in the feces. Populations at risk: household contacts of infected people, sexual partners of infected people, people, especially children, living in areas with increased rates of hepatitis A, people traveling to countries where hepatitis A is common, and injecting and non-injecting drug users. Treatment prevention: there's no specific treatment. You usually just monitor the severity of the symptoms. May be prevented by immunization. So passive transfer of nonspecific immune serum globulin, temporary immunity that lasts about 6 months, given to individuals within 2 weeks of exposure, if not given HAV vaccine previously. Active immunization with HAV vaccine, inactivated virus, highly effective. It does require 2 doses that are given 6 months apart. Hepatitis B. Hepatitis B is a lot more serious, and this one does have the potential to progress to liver cirrhosis and cancer. With this one, there is a vaccine that exists. Typically, those are given as an infant. Within a couple days of birth, you want to start the first dose, and then there's like a series of 3, and you can get boosters later on in life. If you want to go work in healthcare, you got to get an antibody titer for hepatitis B, because hepatitis B is one of the most common bloodborne pathogens that you would find. So a lot of people with needle stick incidents, they think HIV and worry so much about human immunodeficiency virus, when really hepatitis B is much more common to be encountered through needle sticks. It infects the liver and causes inflammation, accounts for 34% of hepatitis in the developed world. Serum hepatitis or long incubation hepatitis. There's 3 primary modes of transmission by body fluids: parenteral, perinatal, or sexual. The Dane particle is infectious HBV. The core is synthesized in the nuclei of the hepatocytes. It contains DNA polymerase, core antigen, HBcAg, E antigen, HBeAg, and it's transported to the cytoplasm. So there's 2 different antigens to make note of. The core antigen is specified by the C. So HB is for hepatitis B. C is the core and antigen AE. And then there is the E antigen, HBeAg. So hepatitis B E antigen. It's transported to the cytoplasm. The surface antigen, HBsAg, is synthesized in the cytoplasm, and that surrounds the core. So hepatitis B surface antigen. And it's very important to pay attention to this little c, the little e, and the little s. The surface antigen, HBsAg, is the Australia antigen, or the hepatitis-associated antigen. It's the first serological marker to appear during prodrome of acute hepatitis B. Antibody versus antigen develops following disappearance of the antigen with clinical recovery. So if we want to know if a patient has a current and active infection with hepatitis B, we want to look for the actual antigen in the serum. So we are going to do a test that determines whether the antigen is present. If we want to know if a patient's ever been exposed, then we would look for antibodies in the patient's serum. Those antibodies are believed to confer protective immunity. The surface antigen testing is performed on all units of donated blood because we want to make sure that there's no active hepatitis B in blood that we're going to be transfusing into other patients. The core antigen is not demonstrated in the serum of infected people. It's seen only in the nuclei of hepatocytes during acute infection. It's closely associated with viral DNA polymerase. Anti-HBC, or antibodies to the core antigen, develop sooner than antibodies to the surface antigen. And this is indicative of clinical symptoms in hepatitis. HBe antigen, so the E antigen, is associated with the core of the viral particle. The presence correlates with the number of infectious particles. The presence in HBsAg positive carriers is a poor prognostic sign. Presence of the antibody anti-HBe versus HBe antigen in carriers indicates low infectivity of serum. So here you can see what, when you get exposed, what antigens are going to arise. So you can see HBe antigen, HBs antigen that arise. HBe is a little sooner, peaks a little sooner than the HB surface antigen. And then once those are there, you're going to start to have recovery. So the antigens are going to decrease because less of the actual virus is going to be in the bloodstream. So as those decrease, you're going to start to see antibody production increase. What's happening is your white blood cells, your B cells, are recognizing and producing antibodies against those antigens. So less virus is going to be present. The viruses contain the antigens, so you're going to see a decrease in those antigens. Then with the immune system picking it up, you're going to see more antibodies being released. Clinical presentation. Incubation period is 2 to 5 months, so extremely long incubation period. Clinical course is extremely variable. 2/3 of cases asymptomatic or produce mild flu-like symptoms. 1/3 of cases develop hepatitis-like syndrome, malaise, irregular fever, right upper quadrant tenderness, jaundice, dark urine. 1% of patients develop fulminant hepatitis. It's rapidly progressive and characterized by hepatocellular death and hepatic failure. 90% of patients recover within 6 months. About 5% progress to chronic hepatitis. And here's another diagram of the clinical course. Populations at risk, babies and young children, that's why we vaccinate super early in life, immunocompromised patients, homosexual men, people dependent on blood products, hemodialysis patients, IV drug users, healthcare professionals, surgeons, dentists, laboratory personnel, phlebotomists. Residual risks from transfusion, 1 in 63,000. Treatment prevention, interferon alpha and beta injections, treatment for 4 months. Oral medications exist. A liver transplant may be necessary depending on the amount of cirrhosis or damage to the liver. Prevention, there is a vaccine that exists, and you can also passively get the HBV immune globulin. So if you're having an active case of it, they may passively give you the antibodies from someone else. So if someone's immune to hepatitis, they're going to take their serum, they're going to get those antibodies out of their serum, and then they're going to inject the infected patient with it, and that should confer some type of immunity. Passively from the mother to the baby can also happen, but that is very short-lived, so it's definitely necessary to get the babies vaccinated. Hepatitis D virus. The Delta hepatitis or Delta agent. It is a satellite virus that is not fully functional and cannot replicate unless hepatitis B is also there. So in order to be infected with hepatitis D, hepatitis B also has to be present. It's concentrated in countries surrounding Mediterranean, Black, and Red Seas, strongly associated with IV drug use, especially in Italy. In the US, 10 to 20% of chronic HBV patients will be positive for HDV. It's a simultaneous co-infection with HBV, results in more severe acute disease, a higher rate of progression to chronic disease, and it's characterized by biphasic ALT serum profile. Majority of patients still recover. Superinfection of chronic HBV carrier, it's suspected in cases of chronic HBV which worsen, often results in the development of fulminant hepatitis or progressive liver cirrhosis. And to kind of draw attention to that fulminant hepatitis, that is extremely fast progression to liver cirrhosis. So a patient that gets infected will likely need a liver transplant immediately. Diagnosis: anti-HGV IgM or HGV antigen, HGV RNA, HGV IgG with HB surface antigen. With co-infection, you see anti-HBC antigen IgM may be declining or absent. With superinfection, HB surface antigen and anti-HB core antigen IgG are present in chronic HBV carriers. So there's a lot of abbreviations going on here, and this is where it would be useful for you to write down all of these different letters and what they mean. And whenever you encounter a question about the hepatitis, viruses or antigens or antibodies on a test or in the future, you want to think about what the question's actually asking. So just to kind of go through here, anti-HDV IgM, that's talking about an antibody. The antibody class is IgM. So if you remember antibodies from immunology, you have IgM, D, GEA. M is usually the first responder. It's going to be in the highest concentrations at onset of the infection. After M kind of decreases, then you're going to start to see an influx of IgG. And IgG is the one that's going to give you prolonged immunity. So that one typically stays in the bloodstream for a really long time. So if you get vaccinated against hepatitis B as a baby, and you get your blood drawn and checked for your immunity to hepatitis B later on in life, in your 20s, 30s, 40s, whatever it is, it's IgG that's going to continue to confer that protection against that. So that's your kind of long-term, most prevalent antibody in your serum. When you say HDV, that's hepatitis D virus. HBV is hepatitis B virus, and so forth. We talked about those extensively. When it's anti, we're talking about an antibody, which means that the immune system produced an antibody against the virus. When we talk about an antigen, or AG, an antigen is a component of the virus. So antibody is a component of your own immune system that's trying to fight the virus. The antigen is the component of the virus, which the immune system is trying to attack. There's surface antigens, core antigens. There's the E antigen with hepatitis B. So it's important to keep all of those clear in your head. Treatments are generally the same for those of HBV, interferon, or oral medications. Hepatitis C virus. So hepatitis C is kind of considered the sneaky virus because it can lay dormant in the body for like 60 plus years. So you can get exposed and then 60 years later have rapid and progressive cirrhosis leading to cancer. And this one most commonly causes cancer out of all of the hepatitis viruses. So this one is non-A, non-B hepatitis. So 80% of non-A, non-B hepatitis cases are hepatitis C. Most common form of blood transfusion-acquired hepatitis. About 3% of blood donors in the U.S. are positive for HCV. Most are presumed to be infectious. Other routes, sexual transmission is rare. The fecal-oral route may be possible. Epidemiology, highly prevalent in the general population, 16% of acute hepatitis cases in the United States, but it's declining with advent of blood tests for detection. Endemic worldwide, estimated 3.9 million infections in the United States. Worldwide prevalence, 170 million. Highest risk are IV drug users, recipients of blood products, organ transplant recipients, and healthcare workers. Clinical presentation, clinically, usually mild symptoms at first. Jaundice is observed within 25% of patients, incubation of 5 to 10 weeks, and it's similar to HBV. There's a high rate of progression to chronicity, cirrhosis, and hepatocellular carcinoma. So that's where I talked about. It's one of the ones that's the most commonly caused of liver cancer. Most common cause of chronic hepatitis in North America and Europe. Treatment and prevention, treatment with interferon and alpha is effective in 75% of cases of acute hepatitis C virus. I am just going to get rid of this because there is a vaccine available today. So they just developed a HCV vaccine within the past 5-10 years or so, and now it is publicly available. A short story about a friend of mine's dad who got hepatitis C virus. So he was a cop, and there was an altercation where he was struggling to arrest someone, and the person ended up spitting blood into my friend's dad's face. In that transaction or that incident, he thought nothing of it, and he went and got tested for a variety of different tests, never got tested for hepatitis C virus, and didn't ever get his blood drawn, so never thought to think about hepatitis C, didn't really know about it. About 30 years later, he started to develop a rapid onset of progressive liver failure. All of a sudden I saw him and he was bright yellow. His eyes, his sclera of his eyes were yellow, and you could tell he was obviously suffering from liver failure. This friend's dad did not drink ever. He was completely against drinking. So it wasn't due to alcohol, but there was something else going on. Come to find out that that incident that he had reported 30 years prior was likely the incident that caused him to get infected with hepatitis C. So by the time they caught it, he had pretty advanced liver failure, ended up needing a liver transplant, and he got his transplant, and now he's doing well. But now there's a vaccine that prevents against that. So good thing that there's a vaccine now, and my friend's dad is doing pretty well with his diagnosis. Diagnosis is through immunoassays. ELISA screens for anti-HCV, recombinant immunoblot assay for resolving indeterminate ELISA results, compromised by delaying the appearance of anti-HCV in acutely infected individuals. Antibody is not detected during the first months of infection, and it's not protective. Genetic heterogeneity of the virus subtypes complicates the diagnosis. PCR is available for viral nucleic acid. Hepatitis E virus is probably the least prevalent hepatitis virus. It's transmitted predominantly via the fecal-oral route, just like hepatitis A is, and it's seen predominantly in underdeveloped tropical countries. Infection is clinically similar to hepatitis A virus. It has a shorter incubation period. The virus is detected in the feces and bile by 7 days post-infection. Self-limited course without chronicity unless they're immunocompromised. Typically mild except for in pregnancy, so 20 to 25% mortality in late pregnancy. Detection, IgM and IgG ELISA for the viral antigen. Virus is also detected in stool and serum by RT-PCR. Hepatitis G virus, also known as GBV-C. Parenteral transmission, most at risk are IV drug users, hemodialysis patients, hemophiliacs, blood transfusion recipients. It's found in 1.5% of the blood supply in the United States. 90% infectivity in recipients of contaminated blood. Disease is mild, and it's detected by RT-PCR. Co-infection with HBV or HCV is common in the exposed groups. Chronic hepatitis, so chronic inflammation of the liver persisting for at least 6 months. Viral or toxic cases. Classic immunologic disease like cell-mediated attack on the hepatocytes. Clinical features are highly variable. Asymptomatic or mild fatigue. Jaundice may or may not be present. Moderately elevated aminotransferase activity is common. ALP is typically elevated but not too high. Alpha-1 globulins are typically increased, and serum albumin is decreased. Causes and diagnostic strategies. So you can see hepatitis B and C, autoimmune 1 and 2, Wilson's disease drugs, alpha-1 antitrypsin deficiency, and idiopathic. Some we just don't know what they're caused from. About 5 to 10% acutely infected individuals progress to chronicity. Neonates and younger individuals are more likely. Natural history, slow progression to cirrhosis, often progress to hepatocellular carcinoma. The treatment is interferon and subcutaneously for about 6 months, and then it's monitored by the measurement of serum DNA levels. So chronic HBV diagnosis, positive, HB surface antigen, anti-HB core, HBe antigen, negative for anti-HBe. The antibody that protects against the E antigen is very protective. But if you're going to have a form that progresses as bad down the line as being chronic HBV, you're not likely to see that antibody against that E antigen. AST/ALT is elevated moderately. If it's normal, it's not a significant disease. Serum albumin may decrease in more advanced disease. Extrahepatic complications, polyarteritis, glomerulonephritis, polymyalgia rheumatica, cryoglobulinemia, myocarditis, or Guillain-Barré syndrome. And here you can see that progressive or prognosis. Chronic HCV, most common chronic viral hepatitis in North America. 80% of HCV infections become chronic. High risk of cirrhosis. Mechanism of viral persistence is not fully understood. The ability of the virus to mutate under pressure. Persistence in lymphocytes is also an issue. Mild chronic hepatitis to severe chronic hepatitis to cirrhosis and then to hepatocellular carcinoma. The rate of the progression may depend on the viral genotype and the environment of the infection. Alcohol ingestion, male gender, genotype 1 all lead to an accelerated course. Clinical features, wide variety of extrahepatic manifestations, autoantibodies, concurrent immune disease, diagnosis by RT-PCR for the viral DNA, treatment again is interferon, in combination with a drug in 50% of the patients. Autoimmune chronic hepatitis, chronic inflammatory reaction detected against hepatocytes, sometimes bile ducts. Hypergammaglobulinemia, serum autoantibodies are common. Liver and non-liver autoantibodies. The diagnosis is based on the existence of antibodies, abnormalities, and characteristic histology. Prognosis for untreated disease is poor. Most individuals progress to cirrhosis. Hepatocellular carcinoma is rare. There are some drugs that can be used as therapy as well as liver transplant. Metabolic liver disease, Wilson's disease, hepatocellular degeneration, autosomal recessive disorder manifested by neuropsychiatric syndrome or chronic hepatitis. Copper is typically excreted in the bile, and Wilson's disease is what we talked about previously, where we have the deficiency of copper binding cation, and we have copper accumulates in the tissues, and you can see copper in the iris of the eye and so forth. The glycogenosis, excessive and or aberrant glycogen storage in various tissues. Most are inherited, associated with hepatomegaly. Hepatomegaly means enlarged liver. Growth retardation with normal mental development. Diagnosis, excess glycogen by liver biopsy and tissue identification. Malnutrition causes fatty liver, hepatic necrosis, and fibrosis. Kwashiorkor is classic nutritional liver disease or protein-calorie malnutrition. Other nutritional liver diseases include diabetes, obesity, alcohol, and non-alcoholic fatty liver disease, or steatosis, or fatty degeneration. Fatty liver disease suspected on the basis of hepatomegaly, so enlarged liver, and slight elevations of AST, ALT, and CT scans. Diagnosis requires a biopsy. Causes are obesity. The degree of steatosis parallels with weight gain. trivial elevations in AST, ALT, ALP, diabetes type 2 due to increased deposition of fats, third most common cause of liver disease due to hyperinsulinemia, and cirrhosis may be present in about 10% of patients. Non-alcoholic is identical to alcoholic hepatitis by biopsy without the history of alcohol consumption, typically associated with diabetes, obesity, hyperlipidemias. Pathogenesis is unclear. Diagnosis is based on ultrasound, mild elevations of AST, ALT, ALP with normal prothrombin time, and bilirubin. Alcohol, fatty liver of pregnancies, Reye syndrome, metabolic defects, and drug toxicity. Recently, there's been some studies that have been released relating COVID and infection or history of infection with COVID to non-alcoholic fatty liver disease. Tumors, hepatocellular carcinoma, commonly follows cirrhosis from chronic hepatitis B patients. Pathogenesis is unknown, associated with hemochromatosis, alpha-1 antitrypsin deficiency, type 1 glycogen storage disease, porphyria cutanea tarda. Rare with autoimmune hepatitis or Wilson's disease. Laboratory findings for hepatocellular carcinoma, you'd see an increase in that tumor marker that was discussed, CEA, or carcinoembryonic antigen. Markedly elevated ALP and mild elevation of AST-ALT. Progressive elevation of alpha-fetoprotein. Elevated ferritin. Hepatic fibrosis, normal repair process of cell injury. When it occurs in the liver, it leads to cirrhosis in some individuals. Only 20 to 25% of alcoholic individuals develop cirrhosis. There may be genetic factors that determine who does and does not develop cirrhosis. This is detected by liver biopsy.